We appreciate your participation in this important initiative organized by CMAI, UP, and Uttarakhand region and the doctor section. So we hope that this afternoon, this session will be beneficial for you and you'll be able to make the most of it. Thank you so much.
My pleasure to introduce Dr. Ricky Matthew. Dr. Ricky Matthew is already did his MBBS, MD General Medicine, DNB General Medicine, FCPM, NFPM, IPM, Calicut. Did undergraduate studies from the GMC Trivandrum, post-graduation from the GMC Kottayam. Joined the Broadwell Hospital in 2018 as physician and has been working there since then. Currently serve as the medical superintendent of the Broadwell Hospital, Fatehpur, UP. This hospital has a 10+ year experience in the delivering the palliative care services to the community of Fatehpur and has had a privilege to serving nearly the 800 patients with advanced and life-limiting illness. Thank you.
Thank you so much, Dr. Sandeep, for introduction. There are few instructions for the participants. If you are joining as a group, so please do let us know that you are from where and which institution. As well, if you are joining by any device name, kindly rename yourself. And now I would like to call Dr. Ricky to do the to share their screen. So,
Good afternoon, everybody.
good afternoon, sir.
Yeah, I hope my voice is audible. Yeah, it's a privilege to be online with all of you. And CMAI has been an organization which I've been, reading and watching in different scenarios, and to be a part of it and to be able to present is a privilege, and I take it as a grace from God. So I come from the hospital, Broadwell Christian Hospital in Fatehpur. So on behalf of everyone, every staff and the management of BCH as well, our warm regards to everyone present over here. Am I allowed to share my screen? So I like the term that was coined, the Morphine Protocol. So I use the same thing for my presentation as well. So the entire talk is going to focus on this one drug called morphine. And I hope I'm audible. In case there's any difficulty in hearing, please let me know. So yeah, morphine is, as we all know, is derived from this particular plant called poppy. The biological name is Papaver somniferum. And it's been known since ages to have analgesic or pain relieving properties. And as early as 1800s, its analgesic properties were used commercially. And as you can see here, India is one of the largest producers and exporters of this compound. And the three states where the production occurs legally are these: UP, MP, and Rajasthan. So in these three places, licit or legal production of morphine occurs, and the government opium and alkaloid factories extracts the compounds and the biologically active compounds, and they are exported to the larger extent, and a small proportion is what is being given to our country for use for medical purposes. So as I mentioned, we have had many analgesic drugs over the years, but then the significant analgesic properties of morphine were known since ages back and were used commercially since the 1800s. But as you can see, the word just below that, the statement just below that it was very commonly abused as well. So immediately, as soon as it was known that it had analgesic properties, also people got to realize that it has got sedating, and it has got other narcotic properties as well, and that gave it an addictive potential. And so, as mentioned, is a statement derived from Wikipedia, where morphine, it's mentioned that morphine was the most commonly abused narcotic analgesic until heroin was synthesized and came into use. So because of this, abuse or misuse of morphine, the governments across the world had to bring in regulations so as to restrict or curb the misuse of this drug. And so in India as well, passed this act called the NDPS Act, the Narcotic Drugs and Psychotropic Substances Act in 1985. Now, this act was actually passed probably with the well intention of trying to prevent the misuse of the drug. But what it also did was make it very prohibitory to use morphine and other opioids for medical purposes. So under this act, it required multiple licenses. Any hospital or any clinic that wanted to stock and dispense morphine had to get multiple licenses. And also, there was a fact that there were major punishments for even minor clerical offenses. So all this meant that most of the pharmaceutical providers and the clinicians were very reluctant to procure, to stock and dispense morphine. And so because of that, many people who would have benefited quite a lot from this wonder drug were not able to avail of this drug over the years. Whereas in the West, in the Western countries, they were able to use this drug that God had given for pain relief. So, as a result of work done in collaboration with the Department of Revenue, now the production and the sale of narcotics comes under Department of Revenue, which comes under Ministry of Finance. There were many international policy analysts and the palliative care community and the legal community that worked together as a part of a major move of advocacy. And they led to this amendment of the NDPS Act in 2014. Now, many key people across the country were involved in this move and in this effort. And as a result of that, the Act was amended in 2014. And the main principles that were brought about by this amendment was that access to pain relief is essential. Even though we know that curbing misuse is important, in the same way, access to pain relief is also something that we cannot negate or we cannot restrict for the suffering person. Opioids are safe and effective and hence essential to the management of severe pain. So based on these principles, they made it easier to procure license, and the entire the essential narcotic drugs, one short list of ENDs or essential narcotic drugs, which comprises 6 common analgesics, which includes morphine, methadone, fentanyl, and a few other codeine and codeine derivatives. 6 drugs were classified together as ENDs, and uniform rules for ENDs were made across the country. Whereas earlier we used to have different laws across states, now they made it a single system of law across the country. The state drug controller or the food and drug administrator was given the role of recognizing institutions as RMIs, recognized medical institutions, to stock and dispense ENDs for a period of 3 years. So all these were some of the changes, some of the major changes that were brought about by the NDPS amendment in 2014. So I mentioned 2 terms, RMI and RMP. RMI is a medical institution that is officially recognized by the authority, by the prescribed authority, that is the state drug controller, who have been given the license or the authority to purchase, possess, and dispense essential narcotic drugs. That is RMI. And an RMP or registered medical practitioner is a medical practitioner or a dentist who has undergone training in the medical use of these drugs. So any person who has undergone medical training in the use of these drugs are allowed to be part of an RMI and allowed to stock, possess, and dispense essential narcotic drugs. So this training in the medical use of ENDs is not very well clearly defined yet. There are some states which say that they need to have at least 10 days of hands-on with regard to training before which they can be called as a registered medical practitioner. So, despite these changes way back in 2014, now 2014 is almost 11 years back. Even though this amendment occurred in 2014, even now, if we look across scenario across India, we see that many patients have pain, severe pain of various sorts, cancer pain and non-cancer related pain, and many of them are still unable to avail of morphine. And one of the reasons, because there are many myths and myths that are associated with morphine, which even the medical practitioner or the layman is faced with, and because of that, they either fail to prescribe or fail to avail of this wonder drug. So we look at some of the myths and facts that morphine has been associated with over the several years. So I'll just put it across to the crowd over here. Oral morphine causes addiction in terminally ill patients. Maybe if you could put your response in the chat box, it will be helpful. Is this a myth or is it a fact? Oral morphine causes addiction in terminally ill patients. Yeah, so it is a myth. Even though we read that morphine is a very addictive, as a drug with a major addictive potential, what we see is that when morphine is used for patients with terminally ill, terminal illnesses, especially with cancer-related pain, there is a there's a very low chance of addiction in such people. So the entire thing that morphine can cause addiction in such patients is actually a misguided fact. Second statement, morphine causes death in all dying patients. Is this a myth or a fact? Yeah, I think I can see some people who put myth in this. So this is also another myth. Morphine does not cause dying. In fact, morphine, the main purpose and the main role of morphine is only as an analgesia in the terminally ill patients. If morphine is used in the right dose, in the right way, it does not harm the other systems of the body and or lead to death in the dying patients. Morphine always causes nausea, vomiting. This is another statement that many people are confronted with. Many medical practitioners feel that morphine will always cause nausea or vomiting. Now, this is also another myth. Morphine causes nausea only in around 30%. Around 1 in 3 patients who take oral morphine have the issue of nausea and vomiting. And as we see later, that there are good treatments or good medicines that can be given to prevent this side effect in these patients as well. So now coming to some of the facts with regard to morphine. Morphine is among the most effective, if not the most effective, pain relieving medicine available for cancer and for non-cancer illnesses. Most patients with terminal illnesses, cancer and non-cancer patients, suffer from pain, and many of them have very severe pain. Now, many of us know that pain is rated according to a scale that varies from 0 to 10. And many of these people have pain that goes from 7 or more than 7. And they are called to have severe pain. And many of these patients will not be relieved by the normal NSAIDs and other drugs that we commonly prescribe over the counter. And they need higher drugs. But there is still a gross mismatch between the need and the actual availability of morphine to those who need it, which is why this kind of a seminar, this kind of a awareness is important for all of us across. When I did my undergraduate and postgraduate course around 10 to 15 years back, we were never really introduced to these things, the importance or the realities about morphine. We were taught a lot of other things which were important medical facts, important medical principles. But the fact that patients who are in pain have an option with them, patients who are suffering in pain need not suffer in the same way. They have an option for care that they have was not something that was told to us. And it's only after several years of advocacy that now palliative care awareness into the medical fraternity has also been recently introduced. So, due to all these myths that are prevalent and the lack of awareness of the facts about morphine, there is still a gross disparity, a gross mismatch between the patients and vast number of patients who require morphine and those who are right now able to avail of this drug. Now, before going to morphine per se and the effects and the other aspects of morphine per se, I'll just take 2 slides to describe 2 key concepts. One is about palliative care, and the second is about pain in itself. So this is the definition of palliative care, that it is an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illness. Now, one key term here is life-threatening illness. So some people feel that palliative care is only for cancer patients. They're only for patients who are in their terminal stage, who are dying. But no, what palliative care is for people who have life-threatening illness, and it can even begin at the time of soon after diagnosis or at the time of diagnosis itself, and it continues even after death. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. So the second key term that we can see is suffering. So palliative care aims at addressing suffering. Now we know that many people of us who are doctors over here, we have many areas of expertise. I may be a physician, there may be surgeons or gynecologists or other specialists out there who know what we can treat and what we can cure and what we can take care of. Can relieve the patient of. But there comes a time in every person's life or in many patients' life where the cure is not possible. And palliative care steps in even at that time saying that care is always possible till the very end. And so suffering is a reality of life that every patient goes through. And palliative care aims to prevent and relieve suffering through early identification, correct assessment and treatment of pain and various other problems, whether physical, psychosocial, or spiritual. Dame Cicely Saunders is one of the key figures in palliative care. Her story is actually a remarkable one of a Christian lady who began as a social worker, and as she cared for patients who are going through terminal illnesses and difficult situations, felt that she needed more equipping, and so she went on to study nursing and became a nurse. And after working for some time as a nurse, she understood that she needed more training, more equipping to further be of more better use to her patients. And she went on to become a doctor as well. And she put forward this concept of total pain concept. The pain that we call pain in our layman's term is not just the physical pain that the body suffers from, but it has also got social aspects, emotional aspects, and also spiritual aspects. Physical pain is one thing that all of us are familiar with. Our body hurts, maybe a nail has pricked me, or I have touched a hot object, immediately my body begins to ache or pain because something has happened to my body. And there is some degree of distress that is caused because of the physical pain that interferes with our life. Pain can be mild, pain can be severe, as I mentioned. But there is also other underlying elements of social pain, especially when a patient is having an illness like a cancer or an advanced disease. Often there are questions about what is going to happen to their family after, if things don't go well. What will happen to my daughter? Will she get married, or will she remain unmarried and single? The question of loss of role, where I was earlier a farmer and I was earning for my family, and I was also the member of my religious community. Right now, all those roles have been relinquished, and people are avoiding me right now. So many social stigma, social distress, social questions are also underlying the pain that the patient is experiencing. Emotional questions, emotional difficulties. Patients suffer from anxiety, depression, and various other forms of emotional and psychiatric concerns that they go through. Spiritual concerns. Often patients feel that what they're going through is because of something that they've done in their life, and the whole point, the issue of guilt, of having done something wrong and I'm being punished for it. Or again, the same questions of what will happen to me after I die? Is there a life after this? All these questions are what they struggle with, and all of them contribute and add on to the pain for that patient. So pain, as I mentioned, is not just physical, but it's also emotional, social, and it is spiritual. Now, when we just go at the physical pain, the pain, the levels of pain, the severity of pain, the WHO proposed an analgesic ladder way back in the 1970s, 90s, and 80s. It proposed this analgesic ladder where it divided pain and the treatment modalities into three categories. For mild pain, step 1; for mild to moderate pain, step 2; and for severe pain, step 3. Now, for mild pain, which is a score of around 3 on the pain scale, just a non-opioid analgesic with or without an adjuvant therapy is sufficient. Whereas for mild to moderate pain, we can use a weak opioid with or without a non-opioid, plus or minus adjuvant therapy. Whereas for severe pain, we need a strong opioid, a non-opioid, or an adjuvant therapy. So this is the WHO analgesic ladder, and this is what most palliative care physicians and many other pain and pain care physicians use in their management of pain in their clinical settings. So for mild pain, it's non-opioids. For mild to moderate pain, is weak opioids, and for severe pain, it's strong opioids. So what are these non-opioids, weak opioids, strong opioids? Non-opioids are drugs like paracetamol and the other NSAIDs that we know. Ibuprofen, diclofenac, aceclofenac, naproxen, all these NSAIDs fall under non-opioids. Weak opioids include codeine, dihydrocodeine, tramadol, then some other drugs that are not very common, tapentadol, oxycodone, and then of course buprenorphine, which is available as patches and other formulations. Strong opioids include our topic of discussion, morphine, and also fentanyl, and the drug that is now coming into prominence, that is methadone. So these are the non-opioids, weak opioids, and strong opioids in the earlier WHO analgesic ladder. We also have adjuvants. Adjuvants are drugs which add on to the effect of the analgesics, and they include antidepressants, convulsants, steroids, muscle relaxants, laxatives, antispasmodics, among many other drugs. So all these drugs have been used together in various combinations to achieve the pain relief. And again, as we go back, as I said, for step 1, it is non-opioid alone with adjuvant therapy. Whereas for step 2, it's weak opioid plus or minus non-opioid plus or minus adjuvant. And for severe pain, it's strong plus or minus non-opioid plus or minus adjuvant therapy. Now, the WHO analgesic ladder prescribes that the pain relief or the analgesic measures should follow some principles. One is by the clock, second is by the mouth, and third is by the ladder. By the clock means often as medical practitioners, we tend to treat pain as a thing of now, but not of the later. Meaning, as and when pain comes, we try to address it with PRN medications. We give PRN aceclofenac, PRN diclofenac for pain, or PRN tramadol. That is, when the pain is there, you take the medicines. When the pain is not there, you don't take the medicines. But when we deal with chronic pain and pain that most patients who are in the realm of palliative care suffer from, which is mostly the chronic pain that I'm talking about, they need pain relief measures round the clock. They can't just manage with pain management this on a PRN basis. So pain medications should be given according to the duration of action of the particular drug round the clock. That is what the meaning of by the clock. By the mouth means rather than emphasizing on intravenous or other parenteral routes, we try to manage the pain by giving simple oral preparation of the drugs, which are easy to administer and can be administered not just in the hospital, but also in the home setting. And third thing is by the ladder. Rather than jumping here and there and grabbing hold of any medicine that we have or any medicine that we feel like adding, there is a sequential or a structured aspect to how we manage pain. That is called by the ladder, as we saw from step 1, step to step 2 to step 3. But the WHO also gives this that if the patient is clearly suffering from severe pain, if the patient is clearly suffering from pain that is of an intensity of 7 or more on the pain rating scale, and it is interfering with his sleep and his basic functioning, then we are allowed to go straight to step 3 and give strong opioids like morphine to relieve the pain. We are not justified at that point of time in going from step 1 and then waiting to go to step 2 and then to step 3, but we can go straight to step 3. But as far as possible, we have to go by the ladder. Individualized treatment. Now we know that not every person is made the same. We are all made uniquely in the image of God, in our own different ways, in the image of God, and we have our different, compositions. So a drug that works for me may not work for you. So we all have different ways in which the medicines act in a good way, and even with regard to side effects also. So each patient should be treated individually, and the treatment should be tailored for that particular person. And adjuvants also have a major role in adding to the pain relieving effect of the various analgesics that we mentioned, that is the opioids and the non-opioid analgesics. So that was the WHO analgesic ladder that we all have learned. Now, recently, there has also been a move towards adding step 4. Now, as you can see, step 1, step 2, and step 3 of this ladder is also very similar to what we saw in the earlier ladder. Whereas step 4 that we can see over here includes, as it's mentioned over here, nerve block, epidurals, PCA pump, neurolytic block therapy, all big names, but basically they mean interventive procedures that can be used for relieving severe pain or moderate to severe pain that the patient is suffering from, which may not be responding to the other medicines that we're giving him. So step 4 or interventions are a new and very interesting and an exciting modality that's come up recently with regard to pain management over the last few years. Right. So having had that brief overview of what palliative care is, we said palliative care deals with life-threatening illnesses and not just cancer, but it involves life-threatening illness of cancer and non-cancer domains. and it's deals with suffering, and suffering not just in terms of pain but also other symptoms. And these symptoms, whether it's pain or other symptoms, have four aspects. It's about the physical, it is about the emotional, the social, and the spiritual. So, and we also saw briefly about the WHO analgesic ladder, where we have three steps of analgesia that we can give. Now, having have that brief overview, now let's step into the main topic of today, that is morphine. So, as I mentioned in the first initial slides, morphine is derived from the plant called poppy. So, it is a major alkaloid, natural alkaloid of opium derived from poppy. And WHO has classified it as essential drug right in the early years itself. It has classified it as an essential drug because of its potential use. Now, the routes of administration of morphine are several. As it's mentioned over here, oral route is definitely there, and also intravenous, subcutaneous. These three are what are most commonly used in our palliative care, in the palliative care domain. We use these three, oral and intravenous in our hospital settings, and subcutaneous is often useful in the home settings where patients cannot take orally, are given subcutaneous formulations of morphine. And also there is intrathecal and epidural morphine as well. So these are the various routes of morphine. Obviously, there are other forms of other routes as well, which are not very relevant in this presentation, so I'm not mentioning those. Oral preparations. Morphine is available in various preparations. Out of the most common are 10 mg immediate release, but there are also other preparations which include 20 mg, 20 milligram, 30 milligram, 50 and 60 milligram as well. All of these are immediate release preparations. Morphine in the form of solutions is used only in very few centers across India. And also there is a sustained or controlled release tablets of morphine in the dose of 10 milligram, 30 milligram or 60 milligram sustained or controlled release preparations. So these are the various oral preparations of morphine: immediate release, solutions, and sustained or controlled release. Now, the dosing of morphine is based upon its duration of action, which is roughly around 4 hours. So morphine, if it's taken on a PRN basis, that effect of that particular tablet or that particular dose of morphine will wear off by the time of 4 hours, which is why it is very important, as we mentioned, that by the clock dosing is very important in management of chronic pain that we deal with. Now, the one principle to remember is that when we start off morphine dosing in patients, we start by using immediate release preparations, and only once the pain relief is adequate and stable are we justified in switching to the sustained release preparations. Now, the usefulness of sustained release preparation is that they can be given at a lower frequency of twice daily administration, whereas the regular morphine has to be administered around 5 to 6 times a day. SR or CR preparations can be given twice daily. So in that way, it's convenient. But SR or CR preparations cannot be given when the patient is just being initiated on morphine. There is also the concept of breakthrough pain and rescue doses. So a patient who is taking his regular doses of morphine, if he develops pain after he's taken his regular dose, if he still develops pain, that is called breakthrough pain. And in the context of breakthrough pain, the bystander or the patient is asked to take a rescue dose, which is the same as a regular dose. So if the regular dose is 10 mg of morphine that the patient is taking, say, at 10 a.m. and the patient has pain again at 11 or 12, 11 or 12 a.m., 11 a.m. or 12 p.m., then they can take one more extra dose of morphine that is called a rescue dose. Now, this is a sample prescription of morphine for a patient who is having severe cancer pain, and the pain score for that particular patient was 8/10, and he was not responding to conventional analgesics. As I mentioned, if a patient comes to us with severe pain and the pain score is 8 or 7 or more, we are justified in straight away going to morphine. We need not go to other NSAIDs or weak opioids. We are justified in straight away going to morphine as our first line analgesia. So the prescription includes a patient's name, his age, his gender, and his address as well must be added, and the treatment. So the treatment includes tab morphine, 10 milligram Q4H for 7 days, tab bisacodyl, which is commonly one common brand is Dulcolax, 10 mg at bedtime for 7 days, and tab haloperidol 2.5 mg HS for 3 days, again at bedtime for 3 days. So ideally, the number of tablets that we're dispensing should also be mentioned in the same prescription. And this should be followed by the name and the register number of the medical practitioner who is prescribing these medicines. So as I mentioned, an RMP is the one who is qualified to stock and to dispense the morphine medicines. So as I mentioned, morphine has a duration of around 4 hours of action. So we give the tablets. This is a usual pattern in which we ask the patient to take the tablet. 6 a.m. in the morning, one tablet, 10 mg. One tablet of morphine we are saying is 10 mg of morphine. And the next is at 10 a.m. And then the third dose is at 2 p.m. After 4 more hours, that is at 2 p.m. Then 6 p.m. And when we come to 10 p.m. in the night, we give 2 tablets. Why we give 2 tablets is so that it covers the 8-hour interval between 10 p.m. to 6 a.m. So we don't want the patient to wake up again at 2 a.m. just for taking morphine. So we tell the patient or the relative to administer 2 tablets at 10 p.m. So this would mean 5 times of dosing for the patient. One in the morning, 6 a.m., 10 a.m., 2 p.m., 6 p.m., and 10 p.m. So we can give a chart like this to patients where they're given a date and the various actually there is a small correction in the table in the arrangement of the dates, but this is the sample table that we can give to the patients so that they can take the medicines on time. And for patients who are unable to read, we can even put maybe the sign of clocks or something that can help them understand better as to how to take the tablets well. So once again, we just go back to the prescription. We saw that morphine is given at 10 mg 4th hourly for 7 days. And we also gave 2 other tablets, bisacodyl and haloperidol. So, but this patient only came to us with pain. So why are we giving these 2 other tablets of bisacodyl and haloperidol? So to understand that, especially for the non-medicos, we have to know what are the side effects of morphine. So side effects of morphine include constipation, nausea, vomiting, which are the most common side effects that we know. Sedation, which is also quite common. Pruritus can occur. Pruritus is itching of the body, which can occur because of histamine release. And of course, respiratory depression, which is also a well-known, but rather rare complication or rare side effect of morphine if we are giving the proper dosing to the patients. So the right-hand side of the table shows the time to development of tolerance, which means if I start morphine, will these side effects persist as long as the morphine is given to that patient, or will the side effects subside after a few days? That is the meaning of tolerance. So as we can see, constipation is always going to be present. So whenever the patient is taking morphine or any other opioid, there is a likelihood of constipation. So constipation never develops tolerance. Whereas nausea, vomiting, as it mentioned here, it's 7 to 10 days, but some books even say around 3 days. Some of the patients may develop tolerance, but nevertheless, within a few days itself, nausea, vomiting will subside. And so does the other side. So do the other side effects of pruritus, which lasts for around 7 to 10 days, and sedation, which may last hardly for 36 to 72 hours, is the dose if the dosing is appropriate. Again, as I mentioned, respiratory depression is extremely rare with the proper dosing in such patients. So because of this, there is a dictum, or there is an adage that says that the hand that prescribes morphine should also prescribe a laxative along with it. Which is why whenever we prescribe morphine for patients, we also prescribe a laxative. Usually we prescribe a stimulant laxative like bisacodyl rather than the other forms of laxatives. And haloperidol or metoclopramide are specific drugs that are used to give are given along with morphine so as to prevent or control vomiting that may result from the initiation of morphine in such patients. So every patient who comes to us for the prescription of morphine for analgesia should be given these other medicines as well for the required time. And as I mentioned, as long as morphine is given, it is always good to give a laxative as well, because constipation is another symptom that patients are often reluctant to speak out aloud, but which adds significantly to the distress. Even when we are otherwise healthy, also constipation actually adds to our distress. We feel uneasy. But so for a patient who's already having pain and many other forms of distress, constipation is indeed a symptom that can be addressed easily and which should be given, and they should be given laxative alongside. Some of the toxic effects of morphine, which are well known, include over drowsiness, hallucinations, confusion, myoclonic jerks, among many others. But these are not very common. As I mentioned, we have had several patients who we've managed over the last several years, who many of whom were on morphine, and we've hardly seen these toxic effects in these patients. Rescue doses, as I mentioned earlier, that even when patients do take regular doses of morphine, there is a likelihood that patient can have breakthrough pain. And when the patient has breakthrough pain, they are asked to take another rescue dose, which is the same as a regular dose. So for the earlier prescription, along with the regular dose, again that is one thing that I didn't mention in the initial slide. That along with that regular dose prescription, we are supposed to mention that rescue dose should be taken. The same 10 mg tablet should be taken as a rescue dose whenever the patient has breakthrough pain. And also when the patient comes back to us for follow-up. Now for the early patient, we are asked them for follow-up after 1 week. So when the patient comes back for follow-up, we need to see that if the patient requires 2 or more rescue doses in 24 hours, the regular dose must be increased by 30 to 50% whenever they come for follow-up. So usual follow-up for morphine naive patients, for the patients for whom we are starting morphine, is around 3 days. But again, depending upon our clinical context, now we serve in an area where the patients come from far off places, or they are unable to come every 3 days because of various reasons. So we usually call them every 7 days and sometimes even up to 10 days because of these concerns. But ideally, it is good to call them every 3 days as we're initiating and as we're titrating the dose of morphine. Morphine does not have any ceiling effect. The upward titration of dose of morphine can occur till the pain subsides or the undesirable side effects set in. So until the pain subsides, we can increase the dose. Now we usually start morphine at a dose of around 5 to 10 mg every 4 hours. So for patients who are having moderate pain, we may be able to give maybe 5 mg or sometimes 10 mg. But those who have severe pain will usually require 10 mg and above. But that dose of morphine can go up to even 20, 30, even 30 mg every 4 hourly as well for some patients. So we can increase the dose of morphine unless any side effects like excessive sedation or the other side effects like I mentioned, like severe uncontrollable nausea, vomiting, or constipation sets in. In some cases, especially in cases like elderly patients and those who have renal failure, the dose of morphine needs to be reduced or the frequency must be reduced. This is because morphine gets metabolized in the body, and there are two metabolites that form. One is morphine 3-glucuronide and the third is morphine 6-glucuronide. M3G and M6G. Out of which M6G is the active metabolite, and that is what is cleared by the kidneys. So when there is renal failure, there is a chance of accumulation of the active metabolite in the system, which means the drug that we gave to the patient will stay in the body for a longer time and will act for a longer time. So to minimize side effects and to prevent toxic effects of morphine, we will reduce the frequency of dose and we will reduce the dose in the appropriate manner. So a sample prescription would be 5 mg or 10 mg Q6 hourly, or maybe even Q8 hourly, or sometimes even BD if there is significant renal dysfunction or in the elderly people. As I mentioned earlier, subcutaneous morphine is another route of morphine, which is very useful in the home setting. We have not really started morphine subcutaneous route in our community, but we've been to places where we've seen morphine being given subcutaneous at homes in rural settings, and they're doing really wonderful work over there. So one such place is Bangalore Baptist Hospital, where we had the privilege to go last year. And the rural palliative care team over there, they do a wonderful job of giving subcutaneous morphine to their patients. And they have really good pain relief with these modalities. And so subcutaneous morphine is useful for patients who have poor oral intake, maybe because of uncontrolled vomiting or for various other reasons, especially patients who have oral cancers or esophageal cancers. All these people may be people for whom oral intake of tablets may be difficult. So in such cases, subcutaneous morphine may be helpful. Family members can be trained to give the subcutaneous morphine. So it is it can be a family-driven morphine administration. A scalp vein set is what is used to give subcutaneous morphine injections. Now, just a few notes on the dose conversions. Again, I'm not detailing much because we have a mixed crowd. Subcutaneous dose is around half of the oral dose, whereas intravenous dose will be around 1/3 of the oral dose. So this is the dose conversion that we have to keep in mind when we convert from various routes of morphine administration. Subcutaneous is half of the oral dose, and intravenous dose is 1/3 of the oral dose. Now, morphine is not just a drug that is useful for pain relief, but it is also other uses as well. It is useful in surgeries as part of anesthesia, but in the context of palliative care, it is very useful in also in case of severe refractory breathlessness. So, as I mentioned, palliative care is applicable even for patients with chronic obstructive lung disease or interstitial lung disease and various other forms of lung or heart pathologies where you have severe breathlessness, often that is refractory to the normal measures. So in such cases, morphine is a very good drug that may be useful. And the ways in which morphine may act include by reducing central perception of breathlessness, by reducing anxiety, and by reducing respiratory rate. So by all these means, the perception of breathing difficulty is reduced for the patient and they are able to feel more comfortable. So this is another very important use of morphine in our settings. So the usual dosing of morphine, unlike in the analgesia setting, as we can see, the patient has not taken opioids before. In an opioid naive patient, the dosing will be roughly 2 to 2.5 mg twice daily, and this can be increased even up to Q4H as needed. But in those with poor renal function, as I mentioned earlier, for the analgesic dosing, the dosing and the frequency of morphine should be reduced maybe even to once a day. For patients who are already on opioids, already on morphine, the regular dose can be increased by 25 to 30%. And if the breathlessness or the symptom occurs only on movement, so it is good to administer morphine just about 30 minutes before that particular activity that causes the breathlessness. So these are the dosing of morphine that can be given for severe breathlessness that can occur in various settings, across palliative care and other domains. So that was in brief about the prescription and the dosing guidelines for morphine and the various side effects that may come, and how to manage those as well. So as I mentioned earlier, the side effects: constipation, we have to give a laxative, whereas in terms of nausea and vomiting, we have to give an antiemetic. Preferably, what we give for morphine and opioid-induced vomiting is metoclopramide or haloperidol, which are the specific drugs, and not ondansetron. Now, ondansetron is a drug that we all use and maybe even misuse across the spectrum of vomiting. But clearly, the textbooks and the clinical practice guidelines say that for morphine-induced vomiting, much better than ondansetron is actually our drugs like metoclopramide or haloperidol. Now coming to the application for applying for RMI status. So as I mentioned earlier, morphine is not a drug that everybody can procure and keep, but it's only allowed for certain registered medical institutions, which are called RMIs. So RMIs must have an RMP. That is the first prerequisite. So an RMP, as I mentioned earlier, is a medical person, as a medical practitioner or a dentist who has undergone training in the use of opioids. Again, the definition is not very clear, but there are some states which have given guidelines that we need to have at least 10 days of hands-on training in the use of opioids for the management of pain and palliative care before he can be called an RMP. So the first step would be to find an RMP who's trained in the medical use of opioids. The second step is applying to the state drug controller for RMI status. So as I mentioned earlier, the whole thing of applying, the whole thing of narcotics drug license and everything was a confused thing, which was it required multiple licenses, but now it's been made more simple and more uniform, where the state drug controller is the main authority to whom we have to apply for the RMI status, and that requires these particular forms, Form 3F, where we apply for RMI status recognition. Along with that, we attach these certificates, the medical graduation certificate and certificate of training in medical use of opioids. Form 3J, annual estimate of requirement of ENDs and the source of purchase. All these must be applied and sent to them along with a covering letter for application for the RMI status. So when the state drug controller, these are the forms, Form 3F and Form 3J. Now these forms are available online, and then it's easy to procure them, and we can use these forms to be sent to the state drugs controller. So once the drug controller receives a form, they are supposed to visit the facility that is applied for the RMI status, and inspect and see that if whether all things are satisfactory or not, and whether if it is satisfactory, they're supposed to authorize as an RMI through a letter of recognition that is called the Form 3G within 60 days of receipt of application. And the quantity of medicines, the morphine and the other medicines, whether it's injectable morphine or oral morphine or other medicine, which include fentanyl or other medicines that we are allotted to procure and to dispense for 1 year is also mentioned in this particular form. Now, once the RMI certificate is issued to the particular RMI, the institute, then we can go ahead to purchase the opioid from the supplier after making a PO and also submitting it to the supplier along with a copy of the RMI certificate. Now, the RMI receives the original consignment along with when they receive the consignment that they have ordered for. They receive the consignment along with a copy of the Form 3C, which contains the details of the consignment and the time of receipt as well. So this is the Form 3C. This is again a part of all the other forms that we are used for morphine procurement and licensing. The final and very important step is maintaining records. So the authority requires us to record daily accounts of every transaction of morphine use according to the format that is given in Form 3D. And for every patient to whom the END was dispensed, the particular details of the patient should be recorded in Form 3E. And the record of every consignment received should also be kept and stored. And the returns for every year should be filed in the format 3I. So all these formats are available online, and the formats are also quite straightforward to fill. So I think some of the forms I just taken snapshots and put over here. So this is Form 3D, then Form 3E for wherein we record the transaction, the dispensing of medicines to the individual patient and the daily quantity of dispensed for each day. So the documentation is important because every time we need to go for renewal of a license, all these things will be looked into. Safe storage of narcotics should be done within a double locking system. A cupboard with 2 locks is what is required. The registers, as I mentioned, should be maintained properly. So the medical officer in charge is the primary responsibility of the stock and dispensing the drugs. He can be helped by other people, other staff who are working, but the MO in charge is the primary person who will be doing who is the primary responsibility of the stock and dispensing the drugs. Renewal of the RMI. So the renewal is through another form, Form 3F. All these are three numbers followed by the letters. So Form 3F is sent from the RMI to the state drug controller, stating the balance of each drug medicine from the year stock, the quantity purchased, the quantity that is given off in the current year, and the balance quantity and the quantity needed for the next year. So this form, when it's submitted, it will be useful in renewal of the RMI. So that's was in a brief about morphine and the various uses of morphine and some of the legalities and some of the documentation aspects of how we can become an RMI, how we can get the license to procure and to stock and to dispense morphine. Now, as I mentioned, RMP is a registered medical practitioner, and any medical practitioner or a dentist who has undergone training in palliative care or in management of opioid analgesics are entitled to be an RMP. So some of the courses are run by the institutes that I mentioned that are given in the slide here. So CMAI has a course which it runs along with IPM, Indian Institute of Palliative Medicine in Calicut, Kerala. It's a national fellowship course of palliative medicine and national fellowship course of palliative nursing, which is a 1-year course with 20 days of contact postings. And also Palliative India conducts several courses in online and offline modes, all of which are useful in being trained as an RMP. So yeah, that I think was an overview of the topic that I wanted to give. So some of the references that I used are these. Yeah. So this is the hospital that I belong to and our staff. So on behalf of BCH, once again, thank you. And we welcome the medical fraternity, anyone who's nearby us, to keep in touch with us and maybe even visit us. I know as Lord wills. Thank you.
Thank you so much, Dr. Ricky, for that comprehensive presentation on the Morphine Protocol. So now we'll open the floor for question, answer, and discussion from participants. For those who wish to ask questions, you can raise your hand and then we'll allow you to speak. You can also put your questions on the chat. I will moderate this session to ensure that we address as many as queries that we are able to take on during this limited time. And while we are waiting for the questions to come, I have a few questions of mine, which I thought just to get us started. Talking about the RMIs, no? About getting registered as per the new amendment. So, what are some of the challenges that you see the institutions may face becoming an RMI?
Yeah.
That whenever we prepare, we are able to prepare well and we are able to overcome the challenges.
Yeah. So, as I mentioned, after the amendment, the things have become very simple. Actually speaking, it's quite straightforward. But there are bureaucratic hurdles that are obviously there in every place, and we come from UP where such problems do occur quite frequently. So as mentioned, these requirements that we have, as long as they fulfill having an RMP on board and having the prerequisites of their certificates and everything on board, we usually don't have much of a difficulty. Palliative India and some other organizations have also been actively supporting us. So when we applied for RMI, this was way back in 2022, if I'm not mistaken. Initially, it seemed to be like it is going to take a long time, but then again, Palliative India had a point person in UP, and who was quite actively reaching out to us, to help us procure the RMI. And that particular person, he actually helped us connect to some people in the correct hospitals and in the correct offices and all, and that helped us to speed up process. And I think within a matter of around 4 months, actually, like I said, 60 days is a norm, but within 3 to 4 months, we did get the license in hand, and since then we've been having the RMI license.
And how easy or difficult is the renewal process?
Renewal has also been quite smooth for us. We've not had to face any major issues so far. Often the difficulty sometimes comes in regard to procuring sometimes after, because recently also we've had difficulties because there have been some issues in the raw material of morphine. So the last 2 to 3 months we are having some interruption in the supply of morphine, not 3 months, around 1 to 2 months. So those kind of issues still do come. Like I mentioned, the need is so much and the availability is still very little for the tablet or for the.
So, any questions? Yes. Yeah, we've also a response from saying that Palliative has helped Asha Kiran hospitals to get RMI license. Thank you so much for that acknowledgement. And also, just in terms of practical strategies for managing the common side effects. So, how do you? What are some of the common practical strategies that you use for managing side effects of morphine?
So, morphine, usually when we start morphine, it's oral morphine and it is at the required dose. So like I mentioned, it's usually in the dose of 5 mg or 10 mg, or that is a starting dose. So proper counseling of the patient is important because telling the patient that this is a medicine that requires the drug to be taken round the clock, because all of us are used to taking medicines for pain on an SOS basis, because we think that taking more medicines will be, causing more side effects and things like that. So telling them that this is how morphine should be taken, and telling them that these side effects can occur in the initial few days, which include nausea, vomiting, which include some sedation or some weakness more than the usual, which may also definitely include constipation. And preparing them for that is very important. And also being available as a over the phone or whatever. So we serve in an area where many of our patients come from villages, and for them to come, as I mentioned in the presentation, for them to come physically and visit us is very difficult. So we have kept our phone line. In fact, one of our both of our staff are very passionate about palliative care, and they always keep themselves available for the patients. So whenever they call and say that they have any complaint, they are able to provide advice then and there. Because if the patient finds that the drug is causing side effects and we are not able to address it, then they'll clearly drop out, and there's always a major chance of them missing out on what is a big relief for their symptoms and their suffering. So we start with drugs like bisacodyl for constipation, and metoclopramide and haloperidol also along with the morphine. So if we don't do that, again, these are things which we also learned over time as we did these courses and all, which we were not aware of earlier. But now we make it a practice that every person who prescribes morphine should prescribe it along with a laxative, should prescribe along with an antiemetic, so that to prevent side effects.
Thank you, Vicky. Another thing is, any special considerations for people with the special population with renal impairment and other health comorbidities?
Yeah, as I mentioned, again, kidneys are one major organ that are involved in the pharmacokinetics of morphine, and so especially for patients with renal impairment and also people with other comorbidities, people who are elderly, it may be good to start even slow, like even lower with regard to the dose, and even slow with regard to the frequency. So as I mentioned, maybe 5 or 10 mg, but the frequency should definitely be less than 4th hourly. It should be only 6th hourly, or fewer doses than that would be a better way to start off. And from there we can monitor as we call them for follow-up, whether the pain relief is adequate and whether they're having side effects, and based on that we can up titrate the dose. That may be a better way rather than going at a high dose, and when the patient has side effects, they refuse treatment further on from there. So starting low and then up titrating would be a better strategy in such patients.
Thank you, Vicky. I'm still waiting for queries from the participants. Any questions from the participants? Anything that... So while we wait, I have another one for you. You talked about and you showed about the total pain concept from Dame Saunders. So how do you integrate that in patient education? How do you, or not just patient education and also for the relatives, but also interdisciplinary care?
So I think palliative care, even as some of our mentors have also told us, that palliative care is not just a separate specialty that we've embarked upon, but it is added upon our own, added on to our own specialties. So being a physician, or being, I'm a physician, and being in our specialties, we tend to focus on our particular bodily symptoms, and we tend to overemphasize those and try to just quickly hear the complaints and then prescribe something for that and then send them away. But again, palliative care re-emphasizes what we all know, that our body, is not just what we see in the flesh, but it's also about the soul and the spirit. So palliative care is kind of just putting that out in words. So it's also about the body, it's also about the soul, and it's also about spiritual aspect, and the part that they're part of a community, the societal aspect as well. So that makes us spend some time with the patient, spend greater time listening to them, hearing out their needs and concerns, letting them vent out their, feelings and frustrations and, the angst. and then slowly probing questions just so that we can find out where they are coming from, what are their deepest distressing concerns and challenges that they face, how are things at home, who are their dependents whom they're concerned about, maybe it may be their daughter or their child, it may be their wife who's suffering from another illness. So these are things that will only come out if we slowly ask those leading questions. And then of course, what are the support systems that they have in the community and otherwise. So in the OPD setting, often our time is limited in such settings, but we have a very, like I said, our palliative care staff are extremely dedicated. They visit homes. They visit nearly 4 to 5 homes in a day, and they spend nearly half an hour or more in a home. And they just go and sit by the patient's side. Many of the patients come from villages. They are, extremely poor. They live in thatched huts. They have, they don't even have a chair to offer for us. So they just go sit by the patient on the floor or wherever they can find. Just put an arm around them, put an arm around their shoulder, listen to them, hear from them. Even that whole fact of empathy, because often what happens in communities like ours is when a patient uh, is given a diagnosis of a terminal illness, they are neglected and they are kind of put aside, because it is all about daily living. It's about daily labor. So if I am stepping back from my daily labor to care for that person, then I am missing out on my daily wages. So everyone just keeps moving with the pace, and this particular person who is actually suffering, who actually needs the greatest care in that family, is kept in one corner. And so, when our palliative care team goes and visits their homes, that is maybe the first time in a week or in a month that anybody has talked to them and asked them, how are you doing? Are you all right or are you okay? And then many of them just burst out in tears, and they just say, thank you for asking. This is what I'm going through, this is what I'm suffering from. And this that ability to express what they're going through, and to be able to pour out their concerns and their distress and their suffering itself gives them so much of relief. And there are some things which we can address, some concerns which we can address, but many we can't. But like as I mentioned, the communication itself gives them big hope. And of course, we try to spread awareness, because tobacco chewing is one rampant concern that we have over here. Dr. Hanish is also online, as I saw, and he serves in the hospital Kachua. And, all these places, oral cancers is one of the most prevalent cancers that we have over here. And tobacco chewing is so rampant that everybody, literally everybody, from youngsters, children, up to old, dadas and dadis, women and men, everybody are hooked onto this, this addiction. So, promoting awareness as to the harms and the problems of tobacco chewing are also things that we do while we visit homes for such people.
Thank you so much, Dr. Ricky, for also enlightening us about the holistic care that you are providing. I mean, when you're visiting the homes, not just the medical treatment, but also raising awareness on the important aspects. Also, I think the most important is seeing them as people who are created in God's image, and sharing that empathy with them. I think that takes it far for the family members as well, for the caregivers as well. Thank you so much, Dr. Ricky.